Tissue Integrity, Part 5, Introduction to Nursing Concepts, Martha Olson. In looking at our assessment, many complications can arise from our wound and skin. As you look at the 5 listed on the right-hand side of your screen, make a note of one that's the most serious all the way down to number 5, and we will be visiting about that in class, coming up with some rationale why. Hemorrhage is one that the Potter and Perry talks about on page 1183. We know many factors are involved in that clotting cascade. We need to make sure as nurses we're checking that PT, PTT, and INR levels that the doctor has ordered. Hemostasis after a couple of minutes, unless large blood vessels are involved, should be expected. If they have poor clotting, would be another reason why a patient may hemorrhage. A patient on aspirin, Lovenox, Coumadin, or heparin is going to obviously have more risk factors for poor clotting ability. When we look at hemorrhage, this is something you consider immediately after surgery, immediately after an injury. And so it becomes one of those things we look at. Also consider your alcoholic that has liver damage called cirrhosis. Remember, your clotting factors are made in the liver. So if you're caring for an alcoholic or somebody with liver disease or hepatitis, they may have more issues or risk for hemorrhage as a result of their underlying health conditions. In the book, then, it talks about internal and external signs of hemorrhage. Remember, our external hemorrhage is easier to see. It's more visible, and we can see a saturated dressing, a hematoma, a large amount of blood in that surgical drain, and know that we need to get help. With the internal hemorrhage, it's harder to see, and sometimes it is later on before we're able to identify. So we want to look for those early subtle signs. The pulse goes up. They complain of more pain than probably should be expected with that. Their blood pressure drops as a result of hypovolemia or hypovolemic shock. And you may notice some distension or tissue swelling to that area. If you are looking at a drain, it would be frank red blood in there, and it would increase in amount from where it had been, because any drain should have some drainage in it, but it should be decreasing every time you check on that. So our hemorrhage post-op is greatest in the first 24 hours for that surgical patient. Factors that increase the risk for a wound infection. Now remember, your hemorrhage is post-surgical right away, but the infection is going to happen a day or two later because it gives those bacteria time to get in the body and do their thing. On page 1183 in Potter and Perry, talks about the second most common healthcare associated infection is your wound right after your urinary tract infection, the one that we talked about in the elimination unit. A contaminated wound will probably start showing signs of infection on day 2 or 3, whereas a surgical wound 4 and 5 post-op day, you will see that infection possibly start to develop. With a surgical, remember, call the physician, the surgeon, and they will probably order blood cultures ×2, 20 minutes apart. Look to see if it's systemic. Do they have an increased white blood cell count? Are they lethargic? Do they have all of those signs of a systemic infection? And we treat with a broad spectrum antibiotic after the blood cultures have been obtained. In Potter and Perry, it talks about all chronic dermal wounds are considered contaminated. Our signs and symptoms then of a local infection, I'd put a star on this page. Our local is a different color to the drainage. The edges are a little bit swollen, might be a little odorous, with some localized pain, whereas your systemic is more of that fever or that infection that's all over the body, causing them to have a fever and also to have leukocytosis. A bacterial count would be looked at for this patient then. Here is what an infected wound looks like. They're not sterile because they're colonized with bacteria when it's a chronic wound that we see. And sterile technique sometimes isn't the best way to take care of that because it is a chronic wound that's already colonized. So if you see a patient, usually in home, in the hospital we tend to do more sterile procedures, but if you're a home care nurse, you might be doing some wound dressing that's sterile or clean technique but not sterile. Remember, your wound culture is only collected from healthy tissue. So if you collect a a wound culture from tissue that we know is contaminated, we know the results of what's coming back. So you want to obtain your specimen from a clean part of that wound bed. Our white blood cell count we have been talking about in class already. Remember, a normal is about 4 to 10,000. Elevated would be called leukocytosis. It could be from an infection or a meningitis. Perhaps they have appendicitis or a tonsillitis. Can be also from tissue necrosis from things like a myocardial infarction. When that heart muscle is damaged as a result of lack of blood flow to that myocardium, it can cause an infection or a swelling as a result of the insult to that area. A low white blood cell count is often looked at as bone marrow depression. Some of the medications that people take can cause bone marrow depression or a leukopenia. Viral infections cause a white blood cell count to be low. Some of our typhoid fevers or hepatitis mono can be a low white blood cell count as well. Looking at a few things here, our dehiscence is the next complication that we look at. I've seen dehiscence before. It's where the layers separate. It happens most commonly 3 to 11 days after the surgery or after the injury, and your obese patient, because of the extra weight, the extra adipose tissue, it's hard to stitch, and for them to use the sutures to pull healthy tissue together to hold a wound shut. And so that puts a person that has obesity issues at a higher risk for dehiscence. We do not allow a patient to use a trapeze when they have an abdominal incision because it pulls on the sutures and the abdominal muscles when they use that. People that have poor nutrition, that come in already with an infection, will be at high risk for dehiscence. And as I explained in class the other day, that stitches that live in a warm environment, the stitches that are underneath the tissue, will dissolve faster, predisposing this person then to that wound that's not totally healed over yet, or the collagen that isn't healed over, and it rips open. A patient also that's doing a lot of coughing or vomiting can have a dehiscence as a result of the increased intra-abdominal pressure from that. So you may see a surgeon require that you give like an antitussive or an antiemetic, those two medications to help with the coughing and or the nausea vomiting. These are a couple of pictures of what dehiscence looks like. You can see that the inside is coming out and the tissues are not approximated in those two pictures. Evisceration, I put the E and make it an emergency. This is where the layers and internal organs are now protruding from that incision. It's an emergency that you need to know how to handle, because on state boards they will ask you what you would do in that situation. Stay with the patient, cover the wound with sterile saline soaked dressing, put the call light on and ask the ward clerk or whoever answers to send the charge nurse in right away and get the surgeon to come. You know they're going to be NPO, you're going to need a Foley catheter, you're going to need an IV if you don't have those things in that patient, and also a consent to take them back to surgery so they can get them put back inside and closed up again. Decrease the head of the bed so you aren't putting as much pressure on that evisceration site so that they are able to hopefully not have it be any worse. This is a picture then of what that evisceration would look like. I'm not sure in that left-hand picture why that boy eviscerated his internal organs like he did, because obviously he's young and he is not overweight. And then the picture on the right side shows a very red tissue, looks like a colon or something, and that tells you that tissue is probably very healthy and oxygenated because of the color. If it was black or cyanotic or necrotic looking, that would be very worrisome at that point. Your fistula is also an important part of wound and skin. You see this in a variety of patients. A fistula is an abnormal opening between two organs. Mostly I've seen it in women that have had babies and they have had a 4th degree tear down through that rectal sphincter as they are delivering their baby. That rectal sphincter and rectal area is very dirty, and often they will stitch it up, but it will get infected and they will have a lot of problems with that opening between those two organs causing a lot of problems. A friend of mine that had that after a baby wound up having 4 surgeries in attempt to repair that area that had gotten the fistula in it. These are a couple other pictures of what a fistula would look like. You can see in the one on the left, it's between the sigmoid colon and the uterus for the female, and then this fistula then from the wall on into that colon, where again it's very dirty and contaminated. I was not able to find any pictures that showed a live representation of what a fistula looks like, and that's because they are inside and they're very hard to be able to get pictures on them. As we look at our skin assessment on page 1189, we're looking at that Braden scale. We look at the pressure points on that page and how we want to make sure we look at the skin very closely on admission. We want to look under the breast, we want to look on the hips, the greater trochanter, the shoulder, the ears. Everywhere where there's a bony prominence could be potential for skin breakdown. We want to look at that skin again then in a very short period of time just to make sure that things haven't changed and they don't have any skin breakdown. In the hospital where I work, we have the skin assessment come up every shift. We do the Braden scale looking at that risk for skin breakdown so we can take proactive measures to prevent problems. We're looking for the skin integrity. Is it boggy feeling? Is it open? Is there any warmth or coolness to that skin? Does it look tight or shiny with edema? And then is the skin frail and very thin where we're going to get an easy skin tear from that? So skin assessment is something I do not delegate. Many times your nursing assistants will come to you and say, I think Mrs. Jones looks very red on her coccyx. What would you like me to do for her? And then I need to go down and assess the situation. Is she incontinent of feces? Is she incontinent of urine? Is she sitting up too long in the chair without repositioning? And kind of make the determination as to what we need to do and then chart on it. Our Braden scale is one that has been around. It's a very universal tool looking at risk for skin. It's on 1185, and our 6 subscales are their sensory. So on the test, you can expect that I will ask you who would be at highest risk for skin breakdown, and look at your 6 subscales and think of patients that fit that category. Your sensory perception, somebody that has loss of sensation due to maybe they're diabetic and they don't have good sensation to their feet. Perhaps this is a person that's unresponsive, or they have Alzheimer's and cognition issues and they aren't receptive to sensory. Your moisture, that would be anybody that's diaphoretic, sweaty, incontinent of urine, and not getting changed and the skin is not remaining clean and dry. Moisture can also be for very heavy people that have an abdominal apron or under the breast tissue in the groin area, where when they sweat, that moisture just sits in that area and causes skin breakdown. Activity is the amount of walking, sitting in the chair that they are doing, or is this person totally bed rest and they are at high risk for skin breakdown as a result of immobility. Our nutrition is their diet. How much, what quality of food, you know, when they have dysphagia or difficulty swallowing, maybe they are only taking fruit juices that are thickened and not getting protein that would help heal tissue and keep that skin healthy. And then your friction and shear is the person that maybe they lay in bed and they rub their heels against the sheets all day because they have Alzheimer's or they're nervous, or they use their elbows trying to pull themselves up in bed a little higher. The Braden scale we will be practicing on in class as we look at those 6 categories. Our best score is a 23, and anything less than 9 means we need to take some action as a nurse to change some things around to improve the outcome for that person. When we look at identifying those skin changes, we look at pressure ulcers. We're going to also look at our wounds and incisions, and our assessment then is going to be measuring them, which we will be practicing in class, looking at the size, how deep, what type of tissue it is, and how much of that tissue bed do we have to replace with that. This ends our PowerPoint number 5. Hopefully it has helped you to identify some high-risk issues and our Braden scale that helps us then with an assessment to determine their risk for skin breakdown.